I cover personal health budgets, transitions and joint funding. So there are three different branches to my role. Not here to talk about transitions or joint funding today, just personal health budget. So I'll share my screen. I've got a presentation to share with you all. I will go through the presentation. I'm really hoping that it's kind of what you're looking for in terms of information around PHBs and what the ICB do. Can someone let me know when that is visible, please? Perfect. Thank you, Vicky. So what I'll do is I'll run through the presentation. I will then sort of, if we can leave questions to the end so that I can just get the presentation sorted, because some questions you might have might be answered within the presentation, but obviously I'll welcome plenty of questions towards the end. And yeah, so I will start that presentation. I might turn my camera off if that's okay, just because technically my computers struggle to do more than sort of one or two things at the same time, and so I don't want to lose signal. Okay, so basically this is just a quick guide to personal health budgets. I will change the slides so that we've got an information. I feel like I need a Chris Whitty situation, don't you? Change slide, please. But no, I'll do it all myself. Anyway, so personal health budgets, what are they? So a personal health budget is a budget that supports a person's identified health and well-being needs. It's a way of providing a more person-centered approach to support and care, tailored to the individual needs of the person, suitable for all ages with both physical and mental health conditions or both. There is also something called a personal wheelchair budget, and there are three different ways to manage a PHB. The ways in which it is managed, so there's three different ways. There's a notional, a direct payment, and a managed PHB. And depending on the needs of the patient, the wishes of the patient, and identified routes of what they require, depends on which one you go for, if that makes sense. I am about to talk about them separately, so that's fine. But it's about what the patient wants versus what we can provide. So if I go on to the next slide. So the first one that I will mention is a notional PHB. So it's a personal health budget that is managed by the Integrated Care Board, by ourselves. So the beauty of a PHB really is to put a lot of control over to the patient, so that they can be fully involved in their care planning, purchasing care, dependent on which PHB they hold. But we do have this option of a notional budget, so that's managed by the ICB. So essentially, we purchase their care for them from an agency. And you might say, why does that make it a PHB? Because that's the normal route of purchasing care, is through an agency in the community. But actually, what makes it a PHB is simply the transparency of the Integrated Care Board, of what that package of care consists of, how much it costs, and obviously planning that care with the patient. So that's what makes a notional PHB. Okay. So then if we move on to the next slide, so then we've got a third party PHB, personal health budget. So that's when there is an external stakeholder, someone that's not the Integrated Care Board and who is not related to the eligible person, and that is it through companies. So Partner to Care, I don't know if anyone's heard of Partner to Care, or a company called Solo. Those are the two main ones we use in BNSSG ICB, but there are other companies out there that will that are coming through, that are starting to, that can support. For example, we've got one called Ask Jules, which is supporting one of our service users to go to university, which is absolutely fabulous. So we're not limited to Partner to Care and Solo, but those are the two main companies that we use. So those organisations are responsible for sort of supporting the patient in the care planning process, for setting up the personal health budget, to write the care plan that outlines their health and social well-being needs, that sort of outlines the hours they require, the level of the support. They put a budget together, all that sort of thing. They recruit, they support with the employment process, but they do not act as an employer. So when we go back to what I said earlier about the patient having control, if the patient or their representative, if a patient lacks capacity, they will have a representative, they are acting as the employer. So although these organisations support the entire process, they are not classed as the employer. So that's just that. This is where the bulk of our PHB patients sit, either through partnered care or solo. And partnered care, they do managed accounts. They can also set up direct payments. So they're quite broad in terms of what they can offer. They offer the training for the patients on setting up of the PHB, all those sorts of things. So very valuable resource for us to have in the community, actually. Okay. Then if we go on to the next one, so this is the third and final type of, well, excluding wheelchair budget, but direct payment, which is when the ICB, we transfer money into a dedicated bank account or prepaid card is the other option to either the eligible person or their representative, depending on who is the classed as the employer. And they are then taking on the responsibility of purchasing their care, and that is usually through agency. In the community. It also might, if traditionally, if patients have come across from the local authority, they might also be purchasing or paying for their their employed PAs through a prepaid card or a direct payment bank account. I hope that makes sense. It's quite a it can be quite a minefield. So I've been trying to sort of simplify it for myself as well, really, more than anything. So those are the different types of personal health budgets that we support. So then the next bit is I just wanted to sort of outline that who is eligible for a PHB. And there's only 4 sections on here, and I appreciate that doesn't cover a lot of people, but obviously I work for NHS funded care, so we cover the continuing healthcare aspect of PHBs. But PHBs, they're not restricted to just being continuing healthcare eligible patients. So it covers people with a Section 117 aftercare are eligible, children and young people continuing care. And obviously, I have kind of touched on the wheelchair budget as well. So wheelchair services is included in that. And actually, as an ICB, we have all of these services within the ICB. They just don't sit within the team that I work in. So the ICB is obviously quite a big employer. There's a learning disability and mental health cohort to the ICB. There's the children's team that do the continuing care, and obviously the wheelchair services. So that was just to say that it's not restricted to just continuing healthcare funded patients. Okay, so we also, these next couple of slides are going to be seem quite restricting in terms of who is eligible and what a PHB can be used for. But it's just to highlight and back up what I've really said about a PHB holder being a responsible employer. So the people that are not eligible, the cohort of people that are not eligible for a PHB would be offenders on a community order or suspended sentence, offenders on community rehabilitation order, offenders released from prison on licence, people with drug or alcohol dependency who are subject to compulsory treatment orders, drug treatment and testing orders, and then finally youth offenders who are subject to drug and intoxicating substance treatment and testing orders. Now, it does seem sort of quite restricting for these people because you may think, why not? But I think the direct payment regulations have identified that this cohort of patients wouldn't be appropriate for a direct payment element of a PHB, but for consistency within that, they've put it under the whole PHB umbrella because they've just they just wanted the consistency in saying, right, okay, you're not eligible for a direct payment because you come into one of these categories, but actually that's not fair. So we'll do it under the whole umbrella of PHB. So that's the only reason really, because of the direct payment. And that's why that applies. So in terms of a PHB, what a PHB can't be used for, so we have quite an extensive list of 2 slides of things that a PHB can't be used for. So obviously we've anything illegal or unlawful, any gambling or tobacco or alcohol purchasing, surgical, urgent or emergency treatment, prescriptions or dental charges. So that's just to name a couple of those things on that slide. And I think further to that, if we go on to the next slide, we've also got this list of things here because we get a lot of weird and wonderful requests with PHBs. And I think it's really important to highlight the fact that as an ICB, our responsibility, not just with PHBs, but with any patient or service user that we look after, is that we are commissioning their care. We would not, consumables, anything like this on this list is holidays and accommodation we'll put to the side a minute, but anything like consumables, utilities, equipment, transports, those are things that can be sourced in the community through already commissioned services. And so they wouldn't come under a PHB. No equipment. Sometimes if it's recognized that there's an unmet need, or there's clinical exceptionality, then we would signpost people to exceptional funding requests or IFR, EFR, or we would look at being quite creative. And that is the beauty about a PHB, is the creativity that we can hold in terms of framing and building someone's care and support. But if something is already available, then we wouldn't fund it on a PHB, or we would signpost and refer to services that may be able to support. And then when we talk about holidays and accommodation, as I said, we get some very strange requests. And one of them, quite common one, is people asking us to pay for a holiday for them, their family and carers. Now, we some of my colleagues and I have a little joke about this, actually, that we want to set up nhsholidays.com because we get that many requests. But it's not appropriate for us to do that. We are there to meet a person's health and social well-being needs. So the reason I've put that on this slide is because I wanted to talk around it and say that if someone did want to go on holiday and take their carers and PAs with them, of course we would pay the wages of the carers and PAs, but our costings would not go beyond that. We wouldn't pay for holiday accommodation, flights, anything like that. And similarly with accommodation, something that we're doing within the ICB is trying to establish clear routes of escalation. And when somebody requires housing, accommodation, all those sorts of things, it's finding the right escalation routes and referral routes. So that something would be back over to the local authority. And we quite often get these have these conversations with the local authority where they say, but they're CHC eligible. But I think, like I said, going back to, we commission care only. We don't pay for all the extras. We don't arrange education. We don't sort out bus passes and transport and things like that. So it's just to highlight that we would have to sign. If those questions came in from a PHB holder, we can support in signposting, of course, that's what we're there for. But just to make you aware that that would be through different routes, not through us. Okay. So then we go on to the next slide. So just wanted to also say about training for PAs and carers, depending on the type of personal health budget. So both managed account and direct payment would primarily sit with the person setting up that PHB. So with partnered care, they would set up training and education with the setup of the personal health budget. But we, as an ICB, can also support when there's some training that's not very common, or whether it can't be met through partnered care or solo. So for example, I know that we've got a couple of service users out there that have independent epilepsy training through a company called Acorn. We're also looking at sourcing PBM and restraint training through an independent company, because that's been really difficult for us to source through any other avenue. So the training will be, like I said, managed between either us or the organisation that supports setting up the personal health budget. And then obviously with the notional budget, the training and education will fall to the agency that is purchased to provide the care for the patient. Okay, and then the next slide is, this slide is really just to inform about the ICB process of how we set up a PHB and the level of involvement that goes into it in terms of care planning between us and the organisation that's setting it up. We do clinical reviews. We do a clinical review within the ICB. We will then signpost to Partners Care or Solo, who will then do their own clinical review, and we sort of go back and forth negotiating certain things, because sometimes we, back to the weird and wonderful requests, we'll get a request for massage therapy or something like that, and we wouldn't fund that sort of thing on the ICB. I think I won't say there are exceptions, but there are some times where we will look into something like massage therapy, but there would have to be clear rationale of why it's required and why it's not available through community services. But yeah, so we work quite closely with Partner to Care being the main organisation, and once someone becomes CHC eligible anyway, they are identified as having a particular case manager, and that case manager will be that person that goes through the process of a personal health budget referral and setting up and supporting in that process. So yeah, that's just really to outline what we do as an ICB in terms of setting up and managing. So then I wanted to just give you a little bit of a structure of our ICB, but this is limited to the continuing healthcare structure. So this is just the team that I sit in, the funded care team and continuing healthcare. So we have a senior management team, but our continuing healthcare team is essentially split into two. So we've got the CHC team, which consists of three clinical leads and who manage different areas. So one for Bristol, one for North Somerset, and one for South Gloucestershire. And they have their own small teams who assess and case manage patients in their specified areas. And then the other side of our team is our complex case team, and they don't complete that many assessments because they are complex case managers. They will complete assessments if needed, but the main focus of their role is to be complex case managers. So it is what it says on the tin, really, complex case management for patients that there's a lot going on, there's time consuming, difficulties, breakdown in care, all those sorts of things. And I sit within that team as the PHB transitions and joint funding lead. So I don't case manage or assess, but I will support with case management for all of the nurses and do it, and will dabble myself when the complex PHBs come through. But I'm there to support both sides of the CHC team in terms of PHB transitions and joint funding case management. So I hope that gives you kind of like a picture of what our team looks like. And also at the bottom there, I've just put about brokerage and finance, because they are really quite involved with our PHB, well, all of our patients, but we've got quite a lot of work going on with our brokerage and finance teams in terms of PHBs at the moment, setting up and changing things around. So they are key to our PHBs as well, but obviously due to the money side of things, not the clinical. And then on the next slide, I've just put sort of contacts for you to sort of, I don't know if you want to jot this down or I can send it out to you guys and stuff, but it's just, if there are problems that come up in the community for any of our personal health budget holders or any queries or questions, these are sort of routes of escalation. So if it's clinical input or escalation, then it's to come through to the team. Similarly with brokerage and finance, actually, to come through to the same email so that we can signpost out to the appropriate person or team to deal with any queries. And I've also put the partner to care contact, that's their team email and team telephone number, because there are, like I've said, there are main organisation that we use for personal health budgets. I haven't put solos on there because I couldn't find a team one, and I didn't want to put individual contact details on here. But I'm sure I've got a meeting with them, and it's on my list of things to obtain, so I can actually send solos contact details out when I've got them. So that's just for your information, really. And then the next slide is any questions. So I know that's a sort of whistle stop tour, and I hope I'll stop sharing and put my camera back on. And it's a very much a whistle stop tour in terms of what PHBs are in terms of ICB. So please ask. We've already got a hand up, haven't we? Great. Sorry, I can't see who it is. Okay. Is it Shivasri?
Shubhashri?
Yeah. Hi. How can I help? What kind of question do
Hi,
you
I
have?
have a quick question. Someone has been, it's about a child, and he has got a EHCP issued, and there's an option there as a personal health budget and
Mm-hmm.
the EHCP plan, and the family asks that he receives private speech therapy,
Mm-hmm.
whether this can be funded by personal health budget.
No, it wouldn't normally be considered because speech therapy is accessible in the community services through already commissioned services. So speech and language therapy, obviously, I know that's quite a broad thing, but if it's something that's available to someone through already commissioned services, then that would be the expectation and route of referral rather than paying for it privately. So it wouldn't be something that would be covered by a PHB.
Okay, thank you. Yeah.
Can I ask a quick question?
Of course you can.
With regards to knowing when someone's eligible for CHC funding and a budget, what are the criteria for that?
For CHC funding or once
The
they're you
budget.
mean for the
You
personal
said,
health budget.
yep,
So actually if they're CHC funded, we should be offering it. Well, anyone's entitled to a personal health budget, but once someone becomes CHC eligible, they should be offered naturally. It should be a natural progression to be offered a PHB. And actually, it's something that nationwide is being pushed, and the goal is to have most people on a personal health budget if it's appropriate, which is a bigger piece of work that we're doing within the ICB at the moment, because we have. I can't remember what the exact figures are, but we only have about 87 service users on a PHB out of quite a few hundred. And so it's something that should be offered at the point of being made eligible, if not beforehand, if before they become CHC eligible. So if they're local authority supported or funded, then yeah, it would be the expectation as soon as possible, basically.
and how do we know someone's CHC funded? I know that's probably a really obvious question.
Um, I, I don't know from your perspective, if I'm honest, unless you all come to me individually and give me a name and I can put it in our system to
Yeah.
see. But I think it would be. I'm not sure how you guys would find that out, and aside from asking the patient, I guess. But there's not an EMIS tab or anything that says connecting care, is there? There's nothing. There's no information. Yeah. Um. Sorry, that's not.
No,
I'm not.
no, that's fine. I was just
Stand
wondering,
to
of
me on
all
that
these
one.
people that don't have personal health budgets, I was just wondering how we identify, if we come across them, how we identify to you that we've come across somebody that might be eligible for it, or whether the criteria, perhaps I'm being very stupid, what the criteria is in order to get CHC and be eligible for the personal health budget.
I mean, those that are eligible for CHC are by nature very complex patients, and so I think I'm perhaps not giving this enough thought, but I would think that by nature of the patient's needs, there would be evidence whether there would be CHC. If they are, I don't know if you have knowledge of whether many of your service users or patients sit with Partner to Care, because Partner to Care only takes CHC funded patients, so that would be a good indicator in the community if they have their involvement.
Yeah.
But in terms of CHC eligibility, I don't know how you would identify it from your side of things, if that makes sense.
Yeah,
That's a
no,
really tricky one.
and I'm not sure how we know if their partners to care are
Mm,
involved from EMIS unless we go out and we see a folder
yes.
that says partner to care or and a C, a budget, care plan and all the rest of it. I don't know how we would
Mm.
know.
I'm gonna come back to you on that one if that's
No, it's
okay.
fine. I don't know if anyone else has. Shavasri, you say, was it the person that you were talking to had, the funding, and that's how you knew they had a personal health budget?
Yes, yeah, I was supporting his mum, so that's why I know that he has got this care plan issued, health educational
Mm.
health care plan, and that's where it came up. Yeah.
Yeah, I think that's probably the sort of cohort of patients that's going to be easier to identify because they've got children and young people and those transitioning into adult health services. They have a lot of people involved, so it will be very clear if they have CHC funded, or at that point, a child is going to be continuing care funded, not CHC funded. But so they'll be with the children's team rather than the adults team. I know, yeah.
The other question that sort of springs to mind is if someone who has a set up personal health budget has a query on what can and can't be included, would we contact Partners to Care if that's their agency first of all, or would it be contacting you guys to say they're asking about, I know one that's come up and I've seen about increase in cost of electricity and people who are on ventilators and whether that's covered by the personal health budget. I know that's a topical one that's come up. If we got a question like that, would we go to Partners to Care to ask that, or will we come to you?
I would suggest coming through to us actually and going to the case manager for that particular patient with those contact details that I'd put on the screen. If it's just to the normal BNSSG .chc team at nhs.net, it can be signposted to the case manager who could probably very quickly answer that question rather than going through all of the partner to care route and stuff like that. And partner to care might not have had any input on that patient for a while, potentially, whereas our case managers are the expectation with our case managers is that they make regular contact, whether it's fortnightly, monthly, if they're stable. So they would have better knowledge and more up-to-date knowledge on that patient. So probably through us, I would say.
Okay, brilliant. Has anyone else got any questions? Oh, I think everyone's stunned into silence. I think that was really good. It's
Well, I
just
hope it's helped. So
absolutely. Thank you very much for your help, Eleanor. I'm sure there'll be lots of questions along the way, and having the telephone numbers so that we can come to you and ask the questions and find out a little bit more. Because something we were discussing before everyone came online was the fact if we're writing care and support plans, obviously if they've got a personal health budget, there will be a care and support plan already written. I think that was right, wasn't it, Eleanor?
Yes, there will, but I don't know, as we obviously, like you said, we had this conversation before everyone joined, but I don't know how many are kept in houses and whether they would be up to date. And I would be grateful if you guys, if you picked up on that sort of thing, escalated it to us, and I'd explain to Vicky that I have a patient at the moment that is admitted to the acute trust and has a significant change of need, and the organisation overseeing weren't very keen to update his care plan, but I've sorted it all out now, but my point is he's coming out of hospital completely different clinically, and so we would need to have we want clinical oversight, but we want up-to-date clinical oversight. So if you guys ever see those, it would be great for you to sort of escalate. For the most part, we're on it because of our assessment processes within the CHC team, but they're these odd ones that get away, aren't there? So yeah, and also I say at the same time that we are developing our PHB process, and as I said to Vicky earlier, this could be quite fluid. So I'm teaching today on what we do now, but it might change next week and it might change in 6 months' time because we're really trying to put our focus on this area of practice at the moment. So it is a developing piece of work. So as things change, I can always come back and have another chat or, send information out.
It would be really good to see an example of a personal health budget plan. I don't know if anyone else agrees, just to see what they look like. And then also, it would be really useful to know that if they have a personal health budget, that the plan is in the home. Because if we're going out and we can't see they've got a personal health budget on EMIS, and we go out and they haven't got the plan there, there's a possibility we end up writing a care and support plan. I mean, you hope that someone there would have the capacity to say, they have already got a personal health budget plan, but just in case we go out and we duplicate the work, I think it would be really useful. I don't know what everyone else thinks.
Yeah, okay. So I will ask. I actually have a meeting with Partner to Care this afternoon, so I'll ask them if if they're happy for me to anonymize a care plan and send it over to you guys so that you can see. And I will ask them about keeping the care plans in the property and all that sort of thing. And then I can email you, Vicky, and let you know, and you can sort of cascade as appropriate. Would that be okay?
Absolutely. I think it's just the communication. I think for all of us, it just helps a little bit. I think like you, things are evolving and changing so much
Yeah.
that it's really useful to have these sort of discussions so you can see from our point of view we're going out and how, having that sort of knowledge is helpful to us
Mm.
and working through it. So if anyone has any is going out seeing people with personal health budgets and they have any thoughts, just come back to me and I can forward them on to Eleanor.
Mm.
If there's anything that comes up after the meeting, that would be really helpful.
Yeah, that would.
Brilliant. Well, thank you very much for your presentation. That was
Thank
really
you.
good.
Thank
And
you.
what I will do, if it's all right by you, I have recorded the session. I'll
Mhm.
put it on it's just on for the care coordinators and personalised care staff, if anyone needs
Yeah.
it. But we don't put it on the website so that anyone can access it. And if we've got any questions, anyone comes back to me, I'll forward them on if that's all right.
Yeah, that's brilliant. Thank you. And thank you all for your time in listening to my presentation. I will also just add in that actually our PHB policy is available on our external intranet site if anyone wanted to read it. I mean, no one who likes reading a policy, but it is there if you wanted to have a look.
Brilliant. Thank you very much.
All right,
Bye-bye.
take care all. Bye.
Bye.